Hi everyone, welcome to this episode of Quick Care Bites, where we interview experts in the field to distill clinical pulse and wisdom around critical care topics. My name is Chamin. I'm an intensive care trainee and I'll be your host today. Today we have Dr. Jason Phua to share with us about the role of prone positioning in ARDS. So Dr. Jason, perhaps you could start us off with how prone positioning helps in ARDS from a physiological point of view.
Thanks, Chamin. ARDS is, when we look at the chest X-ray, seemingly homogeneously affecting both parts of the lungs and all parts of each lung. But in reality, if we do a CT scan, very often the main pathology is in the posterior parts of the lungs, the back part of the lungs, so the dorsal part of the lungs. And so when we give mechanical ventilation, and when we talk about ventilator-induced lung injury, a lot of it is because of a concept known as the baby lung. So what is a baby lung? Baby lung is just a small lung. And why are the lungs in ARDS small? The lungs in ARDS are small because the posterior parts of the lungs have lots of edema, collapse, shunting. And so when we ventilate patients and the air goes in, the air actually goes in predominantly to the anterior part of the lungs, the less affected part of the lungs. These are the small lungs. This is known as the baby lungs. So even though we did say in previous sessions that we try to limit the volume and the pressure, 6 mL per kg, pressure of 30. A lot of this volume and pressure still goes to the front part, the less affected part of the lungs. And these are the lungs, the parts of the lungs that can become injured. These are the parts of the lungs that can have ventilator-induced lung injury. And so what we are trying to do when we turn a patient prone is to more evenly distribute the volume and the pressure that is provided by the mechanical ventilation. So when we turn the patient prone, imagine that now the dorsal part of the lungs, which were previously being compressed by what? Compressed by the bed, the patient's bed at the back, compressed by the entire weight of the lungs in front, compressed by the heart right in front. Now imagine we have now turned the patient prone, and now these compressed dorsal parts of the lungs are much less compressed. There's no bed that is going to press it downwards anymore. There's no weight of the lungs because the weight of the lungs are now lower down, and the heart is also now lower down. This gives the opportunity for the collapsed edematous lungs with lots of shunt to be recruited by the PEEP that you are providing through the mechanical ventilation. Because of this, we will then see that the volume that you go to provide, the pressure that you provide, now it is more homogeneously spread across both the dorsal part as well as the ventral parts of the lungs. Now, the healthier parts of the lungs are then not subjected to the entire 6 mL per kg. They are protected. There's less volume trauma, there's less biotrauma. And so, actually, overall, broadly, you will see two things. One, because there's recruitment of the lungs, there's less shunt. Therefore, you will see an improvement in oxygenation. Is that good? Yeah, that's good. You can give less FiO2, maybe you can give less P, you feel a bit more comfortable. But honestly, that's not the key reason why we provide prone positioning. The key reason why we provide prone positioning is because of the second broad reason. And the second broad reason is that we want to achieve the benefit of reducing ventilator lung induced lung injury because villi kills. Hypoxemia, the first reason, often doesn't kill. It is villi that kills, and this is the real target that we are trying to mitigate. Prone
Okay.
positioning reduces ventilator-induced lung injury, and that's how it helps in ARDS.
Okay. Thanks, Dr. Jason. So I guess translating the physiology to the patient, when do we reach out to prone positioning as a therapeutic measure in a patient with ARDS?
So there is indications of prone positioning before 2020, and there are indications of prone positioning after 2020. I think most people know what I mean, right? So I'll talk about before 2020. But even though I talk about before 2020, this applies to 2022 today, right? So we're talking about intubated patients, and these are patients who are generally heavily sedated. ARDS. So indications of prone positioning today for ARDS intubated patients would be PaO2 to FiO2 ratio of less than 150. And this is because of previous evidence that suggested that this threshold in studies resulted in improvement in outcomes. So yes, when you have intubated a patient and you have set the FiO2, the P, the respiratory rate, the tidal volumes, you set it according to your usual targets. You have optimized the PEEP. And when I say optimize the PEEP, in general, when you are talking moderate to severe ARDS, you are talking a PEEP of easily 12 to 15. You have optimized the PEEP. And you look at the blood gas after half an hour, 1 hour, 2 hours. And wow, the PF ratio is still less than 150. That would be an indication for prone positioning. The post-2021 that I was referring to is, of course, COVID, right? And there have been a number of studies that look at awake-prone positioning. And I would summarize them as saying that awake-prone positioning possibly, not definitely, works for patients with COVID. And it possibly, not definitely, works better in patients who require some form of additional respiratory support beyond the usual venturi mask or non-venturi mask. So patients who are on high-flow nasal oxygen or CPAP or non-invasive ventilation. So these patients would be patients that I would consider for awake-prone positioning, especially if they have COVID and require additional respiratory support.
In terms of awake-prone, out of the context of COVID ARDS, let's say patients with early ARDS who are not of COVID etiology, has it been studied whether there's a role for awake-proning in these patients?
No. So it needs to be studied. So the first thing I would say is that even for COVID, the benefits seem to be limited to patients with a decent amount of hypoxemia, not the general ward patients on low-dose venturi mask or nasal prongs. No, the studies actually do not show benefits. If at all, patients with high flow or NIV or CPAP. Beyond COVID, no, it hasn't been studied. The other thing I would say is that it is not difficult to understand why the benefits may not be so obvious in awake-prone positioning, because many patients cannot tolerate. There is observational data from randomized control trial, meaning we look at the randomized control trial, we look at the subgroup analysis, we look at how patients actually tolerated the awake-prone positioning, and there is a suggestion that patients who can tolerate longer, you're talking at least 5 to 6 hours a day, 5 to 6 hours a day, they have better outcomes. Now, is it because they can tolerate longer because they are just better, they are well, or is it because that they can tolerate longer, they have prone positioning longer, they can tolerate, they have better protection for the lungs, and that's why they got better? We don't really know. But yeah, I was just going to say that awake-prone positioning, the reason why it may not work as well as we hope it does, and we need to study that, is because if you prone a patient for just 5-6 hours, you're protecting him or her for that duration. What happens to the rest of the day? You're not protecting him. So in order to protect him longer, you need to prone him longer.
Okay, understand. Okay, thanks, Dr. Jason. So maybe just very briefly, could you take us through the evidence behind the indications that you have just shared with us about?
So the main study is the Persever study,
Mm.
and the Persever study, which is almost 10 years ago already, showed that when a PF ratio is less than 150, and you prone the patient, you turn the patient prone, because actually I've read that the word prone is not a verb, right?
Mm.
So you pronate the patient, you turn the patient into a prone position, and you can reduce the mortality by half.
Okay.
By half,
Mm.
and that's a lot.
Yeah.
So that's why 150 is the threshold.
Okay.
Prior to this study, the Persever study, many studies tried to show that prone positioning can improve mortality. They did not. And the reason why is because of multiple different factors. For example, the duration of the prone positioning was too long. The severity of the ARDS is different. The mechanical ventilation practices of the past were different, etc. But as of 2022, the Persever study is the gold standard study that we rely on. I must add a caveat, and the caveat is that we do not actually know if a patient has got less severe ARDS, say a PF ratio of 200, say a PF ratio of 300, we do not actually know today if we prone the patient for a long time, can we actually also have mortality benefits? Physiologically, it is possible based on what I've just said. It is possible that we can still reduce ventilator-induced lung injury, and these have to be studied.
Okay. Thanks, Dr. Jason. And I guess shifting gears to the more practical aspects of putting a patient in a prone position, as we know, it is quite a hefty endeavor and involves many personnel, and it can be challenging. So maybe just a few quick practical questions. For how long do we put them in a prone position? What are some of the precautions? Are there any contraindications, and any other practical tips around prone positioning that we should take note of?
Yeah, so maybe I just very quickly start off and get it over and done with the awake one first. So you have a patient with COVID, he or she is in your ICU, he or she is on some kind of increased respiratory support, high flow, CPAP, NIV helmet, and you try to convince the patient to go awake prone, right? Presumably this patient is alert, awake, hemodynamically stable, no other non-organ issues, non-pulmonary issues. So it's just a matter of lying the person flat on the front, and it is easier for high flow. Why? Because it's just two things sticking into your nose, less cumbersome. It is more difficult for CPAP because there's a mask. It is even more difficult for helmet because there's a big helmet. But if you just go to YouTube and all that, there are videos that it is possible that you can lie the patient on the side. It is not comfortable. And so you want to push for at least 5 to 6 hours a day. What does that mean? That would mean maybe every shift, you're talking 2 hours, 2 hours, 2 hours. I mean, we've seen patients who are so determined that they can go on for 13, 14 hours. It is possible. But it just depends on the condition of the patients. There are issues such as how do you clean the secretions from the high flow nasal oxygen. There are issues like taking a break, letting the patient sit up and eat, etc. So that's awake prone positioning. But for intubated, sedated patients on prone positioning, how long? 16 hours minimum per day, per 24-hour cycle. So you prone the patient, 16 hours later, you will turn the patient to supine. Precautions, I would say the first precaution is don't forget to turn the patient to the prone position. There have been studies, international ones, where despite the very strong evidence for prone positioning, people just don't do it. People just don't do it because of lack of experience. They forget about it. They don't believe in prone positioning. They think too much about contraindications, etc. But it is one of very few things that save lives in patients with ARDS. So the first precaution I would say is be careful. Don't forget that there is such a method.
Okay.
The other things would be when you turn a patient prone, just make sure we don't dislodge anything, right? They have an endotracheal tube, they have wires all over, they have central lines, etc. So minimum, you will need minimum 5 people, one person at the head of the bed, who is the person calling the shots. This is either the respiratory therapist or some clinician calling the shots and holding on to the endotracheal tube very carefully. And then there will be 2 other people on the left side and 2 other people on the right side. And it is a coordinated move where everything that is sticking out of the patient is held on to, and every move is coordinated. So there will be a chief that says, turn to the left lateral and then turn to the prone, etc., etc. So yeah, one important precaution, be careful of the things that are sticking out of the patient and coordinate with a leader who is clearly in charge.
Yeah.
When the patient has been prone, there is actually no need to put all kinds of support below the chest or below the abdomen, because these have not been shown to be useful. Just lie the patient flat on the bed. The only thing we want to be careful about more is pressure ulcers on the face. So remember to rotate the face from left to right intermittently. Some people use bean bags to reduce the pressure as well. That is extremely important.
Okay.
So the first one would be the coordination and all the wires. The second one would be the turning and all that. The third one is just don't turn a patient prone without doing what you really need to do in a supine position. Say you need to set a femoral dialysis catheter. It's extremely tragic if you turn a patient prone and then you realize, oh shucks, I've got to dialyze the patient, you turn the patient supine again. It's going to be so troublesome. So whatever it is, turn the patient prone after setting all your lines. Contraindications, actually, there are not many. There are really not many. I suppose if you have increased intra-abdominal pressure and the patient's pregnant, you've just gone through some massive surgery, and it's just logistically going to be very difficult to turn the patient on the front because of all these physical issues. Yeah, that would be a relative contraindication. What we often hear is hemodynamic instability. That we should not turn a patient prone because the norepinephrine dose is too high, the vasopressin is really on board. And what if the patient collapses? That one is tricky because we are worrying about a hypothetical situation that the patient may collapse when the patient is prone, versus we are not doing something that is known to improve survival. So my personal bias is that even in patients in severe shock on high doses of vasopressor support, I would prone. In reality, what happens when a patient on high doses of vasopressor support collapses and needs CPR? Outcomes are going to be bad anyway. Whereas if I turn the patient prone, I may actually improve survival. I may actually avert the cardiac arrest. So on balance, I do tend to think that proning is important.
Okay. And practically, let's say the patient really collapses and you need to do CPR for a patient in a prone position.
Yeah,
how would you go about doing so?
Difficult. Again, massive coordination. And also, there are methods to, while you are coordinating all that, do CPR in a prone position. And it is not impossible. So I also, I think I should say what happens next. So because 16 hours, right?
Yeah.
So 16 hours, and then you would turn, you more often than not, you will see that the hypoxemia improves. Then you can drop the FiO2, maybe the PEEP a little bit. 16 hours later, you turn the patient back supine. Generally, if you follow the placebo study, you would turn the patient back supine for 4 hours. Why? It is just a way of trying to relieve the pressure ulcers. So 16 hours prone, 4 hours supine. And if you follow the methodology, if the patient's PF ratio continues to be less than 150, so you could check the gas in 4 hours, then you turn the patient prone again. And then the cycle repeats itself. And you keep turning the patient from supine to prone over the next few days if the PF ratio is less than 150.
Okay.
And then when the PF ratio is more than 150 because of recovery, that's when you can stop proning.
I see. And the number of times that you need so would really vary based on the disease severity, how the patient recovers, and all these factors, right?
Yes,
Okay.
yes. Sometimes, and again, if you look at the Perseverance study, sometimes it will take weeks. Sometimes it takes weeks. Along the way, of course, there's the difficult issue of how long do we go for? We need to talk about end-of-life care, palliative care, etc. But yes, if not, sometimes it will take weeks.
Okay, can. Thanks so much, Dr. Jason. I think that's been a very helpful session in helping us to understand the role and some of the practicalities around prone positioning the treatment of ARDS. So once again, thank you very much.
Thank you. Thank you.